Welcome to the Deep Dive. Today we're taking a closer look at squamous cell carcinoma, SCC. We've got some really focused revision notes here.
Yeah.
You know, the kind aimed at high-yield learning, thinking maybe MSRA prep.
Yeah, exactly. So the plan is to break down the key info, what it is, why it happens, what it looks like, the absolute essentials.
Right. Our mission, then?
No.
Simplify SCC, make it memorable, highlight those exam-friendly bits, and practical points, too.
Let's do it. We'll just go through the main areas, connect the dots so you get the big picture.
Perfect. So let's start right at the beginning. What is squamous cell carcinoma exactly?
Okay, so simply put, it's a type of skin cancer. It starts in the squamous cells.
Those are the ones on the surface.
Yeah, the flat, sort of scale-like cells making up the outer layer of your skin, the epidermis.
And it's common, but not the most common.
That's a key point, definitely. It's the second most common skin cancer overall, specifically the second most common non-melanoma skin cancer. And location-wise, yeah, mostly sun-exposed areas, head, neck, arms, hands. But, and this is important, it can also show up in places like chronic wounds, old scars, areas of long-term inflammation.
Ah, okay. Didn't know that.
Yeah, it comes from those keratinizing cells in the epidermis. And yes, it is malignant. It can spread.
Right.
But, you know, often it's more locally invasive. And the good news is it's often highly curable, especially if you catch it early.
Okay, so second most common, watch out for odd locations like scars, but generally curable early on.
Yeah.
That leads us to, well, how common is it? The epidemiology.
Right. Well, skin cancers in general are super common, particularly non-melanoma types. In the UK, SCC makes up about maybe 23% of those non-melanoma skin cancers, so significant.
And are we seeing more of it?
Unfortunately, yes, the incidence is rising, mostly diagnosed in people over 50, but you do see it in younger people too.
And geography matters, I guess. Sun exposure.
Hugely. It's way more common in fair-skinned people, and the rates are really high in places with lots of sun, like Australia, especially among Caucasian populations.
Okay.
Oh, and it's generally more common in men, probably linked, historically anyway, maybe more outdoor work or recreation, so higher UV exposure over a lifetime.
That makes sense. Okay, now, the really big question. Why does it happen? Etiology and risk factors.
If you remember one thing, it's UV radiation, ultraviolet light.
From the sun.
From the sun, yeah, or tanning beds. That's the #1 cause globally.
Right.
Basically, the UV damages the DNA in the skin cells. Over time, if that damage isn't repaired properly, mutations build up.
And that leads to cancer.
Exactly.
Great.
Leads to uncontrolled cell growth, which is the tumor.
Is it only UV, though? Or are there other things?
UV is the big one, but definitely not the only factor. There are others to know. Things like exposure to certain chemicals, arsenic, for example,
Okay.
those chronic wounds or burn scars we mentioned. A weakened immune system is a big one.
Right.
And having had radiation therapy in the past to an area, so key risk factors to list off. Fair skin, history of bad sunburns, using tanning beds, older age, being male.
Any other really crucial ones, maybe less obvious ones for exams?
Yeah, good point. Immunosuppression. Think organ transplant patients on anti-rejection meds, people with HIV/AIDS, certain autoimmune conditions. Their risk is much higher, and the SCCs can be more aggressive.
Okay, immunosuppression is key.
Definitely. Also, chronic inflammation, like in old scars or chronic ulcers. Some rare genetic conditions, like xeroderma pigmentosum, where DNA repair is faulty, or albinism. Even certain types of HPV, the human papillomavirus, are linked to SCCs in specific sites, often not sun-exposed ones.
And what about those things that aren't quite cancer yet, but could become it?
Ah, yes, the premalignant conditions, very important. Actinic keratosis, often called AKs or solar keratosis, and Bowen's disease.
What are they?
AKs are usually small, rough, scaly patches on sun-exposed skin. Often people have lots of them. Bowen's disease is technically SCC in situ, meaning it's confined to the epidermis. It usually looks like a single, larger, persistent, red, scaly patch.
So finding and treating those can prevent actual SCC.
Exactly. They represent that abnormal growth stage before it becomes invasive. So, yeah, UV is the main story, but definitely remember immunosuppression, chronic inflammation, and those precancerous lesions like AKs and Bowen's.
Okay, got it. So UV damages DNA. Risk factors make you more susceptible. How does that actually turn into a tumor at the cellular level, the pathophysiology?
Right. Keeping it straightforward. It starts with those genetic mutations in the squamous cells, mostly UV-driven. These mutations mess up the normal controls on cell growth and division.
So they just start multiplying.
Pretty much, yeah. Uncontrolled proliferation. They divide when they shouldn't, don't die when they should. This builds up into a mass, the tumor, initially just in the epidermis.
And then it invades.
That's the next step if it progresses. It can break through the sort of floor of the epidermis, the basement membrane, and get into the deeper layer, the dermis. That's invasion. From there, it could potentially get into lymphatic vessels or blood vessels, and that's how it can spread to nearby lymph nodes or, much less commonly for skin SCC, to distant parts of the body. But it all starts with that initial uncontrolled growth from DNA damage.
Right. Makes sense. So moving to what we actually see, what does SCC look like? You mentioned it can vary a lot.
It really can be a bit of chameleon sometimes, which is why you need to be suspicious. But typical signs include a lesion that just won't go away. It might be scaly or crusted over.
And bleeding is a bad sign.
Yeah. Big red flag is if it bleeds easily, maybe with minor trauma, or if it ulcerates, breaks open, and forms a sore that doesn't heal properly.
Can you describe the different ways it might look?
Sure. Sometimes it's a firm, reddish lump or nodule. Other times it's flatter, more like a persistent red patch, maybe slightly raised. It can also look quite rough and raised, almost like a wart. Often not initially, but it can become tender or painful as it grows or if it gets infected. And remember the location, think sun-exposed sites. Face, ears, lips, back of hands, scalp in bald men. The classic description is often an indurated lesion, meaning it feels firm or hard to the touch that's crusted or ulcerated.
Okay, let's try a quick mental picture. Say, an older guy, maybe worked outdoors a lot, has this spot on the top of his ear, looks scabby, hasn't healed for ages, feels kind of hard. Is that classic SCC territory?
Absolutely. That's a perfect mini vignette. Persistent, non-healing, firm, or indurated lesions, sun-exposed site like the ear. SCC should be very high on your list of possibilities there. Definitely warrants investigation.
Right. And speaking of possibilities, what else could look like SCC? What are the main differential diagnoses we need to think about? This sounds crucial.
It is, because things can look similar. Top of the list maybe is keratoacanthoma, or KAA.
Why is that tricky?
Because it often looks exactly like an SCC. Grows rapidly, often dome-shaped with a central crusty bit. Even under the microscope, it can be hard to tell apart sometimes. KAs can sometimes resolve on their own, but you can't rely on that, so you generally treat them like an SCC until proven otherwise.
Okay, KA definite lookalike. What else?
Well, basal cell carcinoma, or BCC, that's the most common skin cancer, usually looks different, more pearly, maybe with little blood vessels. But some types, like nodular or superficial BCCs, could potentially be confused. Malignant melanoma, definitely need to consider that, especially the melanotic type.
The ones without color.
Exactly. They can just be a pink or red lump or patch, so they could mimic an SCC or even a pyogenic granuloma. Then there's the precancerous actinic keratosis we mentioned sometimes. It's hard to tell if one has crossed the line into invasive SCC just by looking.
Any benign things that can cause confusion.
Yeah. Sometimes an irritated seborrheic keratosis, those common warty-looking growths older people get, can look inflamed. Pyogenic granuloma, that's a benign vascular thing that grows quickly and bleeds easily, can look alarming.
Okay.
And one specific one mentioned is around the nails periungual SCC. It can look like a stubborn wart or verruca that just won't clear up. So the bottom line is, if a lesion looks suspicious, especially in a high-risk person or site, keep that list of differentials in mind. Don't just assume.
Right. Suspicion is key.
Yeah.
So you suspect it. How do you confirm it? What are the investigations?
Okay, so clinical judgment gets you started, but confirmation always comes down to histology, looking at the tissue.
Biopsy.
Exactly. The key investigation is a skin biopsy. It might be a small punch biopsy or an incisional biopsy if it's large, taking a representative slice. Or, ideally, if the lesion is small enough and you're pretty confident, an excisional biopsy where you try to remove the whole thing first time.
And the results of that biopsy dictate what happens next.
Absolutely. The histology report tells you if it is SCC, how deep it goes, how abnormal the cells look, the differentiation. Based on that and the size and location, you might need further surgery to get clear margins.
Clear margins.
Yeah, removing a safety border of normal-looking skin around the tumor site. The standard margins mentioned are often 4 millimeters for tumors less than 20 millimeters across, and maybe 6 millimeter for larger ones. That's a high-yield detail.
Okay, 4 millimeter or 6 millimeter margins. What about imaging?
Imaging like CT or MRI isn't routine for most small SCCs, but you'd use it if you were worried the cancer had gone deep, maybe into bone or cartilage or spread along nerves. Especially important for head and neck SCCs. And if lymph nodes nearby feel enlarged, they'd need investigating too, maybe with ultrasound and biopsy.
The referral pathway.
Crucial point. Any suspected SCC, especially if it has concerning features or there's diagnostic uncertainty, needs an urgent cancer pathway referral. Usually the 2-week wait pathway in the UK. Prompt assessment makes a huge difference.
Right.
Oh, and the notes also mention TNM staging. Just remember, T is for tumor size and invasion, N is for regional lymph node involvement, and M is for metastasis, meaning spread to distant sites. It's the standard way to classify how advanced the cancer is.
Okay, so biopsy confirms, staging assesses spread, urgent referral is key. Got it. Once it's confirmed, how do we treat it? Management options.
Right. For most typical localized SCCs, surgical excision is the main treatment, the gold standard. Cut it out with those clear margins. That's usually curative.
But there are other ways.
Yes, definitely. Depends on the situation, the tumor characteristics, patient factors. Options include things like cryotherapy, freezing it off.
Like for warts.
Similar idea, yeah, but usually for very superficial or small lesions, or maybe precancers. Curettage and cautery is another option, scraping it away and sealing the base with heat. Again, for smaller, shallower ones.
Okay.
Radiation therapy is important too. It can be used as the main treatment if surgery isn't suitable, or maybe afterwards if there's a high risk of recurrence or if it has spread to lymph nodes.
What about creams?
Topical treatments, creams like 5-fluorouracil, 5-FU, or imiquimod are mainly used for the precancerous actinic keratosis or for SCC in situ, Bowen's disease, not usually for invasive SCC itself.
And for more difficult cases, like on the face or if it comes back.
That's where Mohs surgery comes in. Mohs micrographic surgery. It's a specialized technique used for high-risk SCCs, ones in cosmetically sensitive areas like the nose or eyelids, or for recurrent tumors.
How does that work?
Basically, they remove the tumor layer by layer and check each layer under the microscope immediately. They keep going just until all the cancer is gone, which spares as much healthy tissue as possible. Very precise.
Wow, okay.
And for really advanced SCC that has spread widely, systemic treatments like chemotherapy or newer immunotherapy drugs like cemiplimab, which was mentioned, might be used.
So treatment sounds very personalized.
It really is.
Yeah.
And often, especially for complex cases, it involves a multidisciplinary team, an MDT dermatologists, surgeons, oncologists, pathologists, all discussing the best approach. And importantly, after treatment, regular follow-up is essential to check for recurrence or new skin cancers, plus reinforcing sun safety advice.
Right. Makes sense. So with all these options, what's the general outlook, the prognosis for SCC?
It varies a lot, and those prognostic factors we touched on earlier are key here. For your standard early-stage SCC on the skin, caught and removed properly, the prognosis is generally excellent. Very high cure rates.
That's reassuring. When does it become more worrying?
It's when the tumor has those higher risk features. The notes lay these out nicely. Think. Bigger size over 20 millimeters is a marker. Deeper invasion more than 2 millimeters deep, especially over 4 millimeters.
Okay.
Poor differentiation, meaning the cancer cells look very abnormal under the microscope. If it's invaded nerves, that's perineural invasion. If the patient is immunosuppressed, certain locations are higher risk too, like the ear or the lip, or SCC arising in an old scar or chronic wound.
So those things increase the risk of it coming back or spreading.
Exactly. They increase the risk of local recurrence, spread to lymph nodes, and, less commonly but more seriously, distant metastasis.
And if it does spread far away?
That changes the picture significantly. While distant spread from a typical skin SCC isn't that common overall, maybe less than 5%, if it does happen, the prognosis is much poorer. The 5-year survival rate can drop quite dramatically, down to maybe 25–40%.
Wow.
Yeah. And most recurrences or metastases tend to happen within the first few years after treatment, particularly the first 2 years, hence the need for follow-up.
So catching it early and knowing those risk factors for recurrence is really critical.
Yeah.
What are the main things that can go wrong if SCC isn't treated well or if it's aggressive? The complications.
Well, the complications really follow from its potential to grow and spread. Locally, it can destroy tissue if it's near the eye, nose, mouth. It can invade those structures, causing functional problems, issues with sight, breathing, eating. Nerve invasion can cause pain or numbness. Then there's spread to lymph nodes. That requires more treatment, like surgery, to remove the nodes or radiation, and it definitely worsens the overall prognosis. And then the most serious complication is distant metastasis, spreading to organs like the lungs, liver, or brain, which we just discussed has a poor outlook.
And cosmetically, it can be an issue too.
Absolutely. Depending on the size and location, the tumor itself can be disfiguring. And the treatment, especially surgery, can leave scars or defects, particularly on the face or hands. So again, it all comes back to early detection and effective treatment to minimize all these potential problems.
That's quite a journey from potentially just a little rough patch to something with significant implications if it's not managed properly.
It really is. Understanding the whole spectrum, the risks, the appearance, the need for biopsy, the treatment options, and what predicts the outcome, that's really the core of managing SCC effectively.
And seeing how those factors, size, depth, immune status, can dramatically shift the prognosis really drives home why understanding these details is so important, especially for exams, but just for general knowledge too.
Exactly. It's about building that mental framework so you can recognize it, know the next steps, and understand the potential outcomes.
For more free MSRA revision resources, definitely check out freemsra.com. And for the full premium revision toolkit, head over to pathomsra.com.
And maybe just a final thought to leave you with. Given that UV exposure is the main driver for the vast majority of these cancers, and we know how to protect ourselves, sun avoidance, clothing, high SPF sunscreen, it does make you wonder, doesn't it? How do we better bridge that gap between knowing the risks and actually changing long-term behavior on a large scale to prevent conditions like SCC? Something to think about.